So Dr. Wyatt is a board-certified emergency medicine physician with specialized expertise in advanced wound care and hyperbaric medicine. Dr. Wyatt earned his medical degree and completed his emergency medicine residency at the University of Iowa. He spent several years practicing at the St. Alphonsus Emergency Medicine Department before transitioning into wound care. He completed additional advanced training in wound management techniques and hyperbaric therapy. Dr. Wyatt treats a broad spectrum of wounds, including traumatic injuries, infections, pressure injuries, edema-related wounds, and complications from cancer treatment and diabetic foot ulcers. Outside of medicine, he enjoys spending time with his family, exploring Idaho with running, biking, hunting, and skiing. So on to you, Dr. Wyatt. Welcome.
Great. Yeah, thanks for having me. Yeah, I really appreciate the opportunity to kind of talk about wound care and the wound clinic. So I'm going to get this kind of set up here. I'm going to share. And then you should see my slides. Does that look good to you guys?
Yeah, looks great.
Yeah, you do. Okay, fantastic. Yeah, so kind of what we're going to talk about today, fundamentals kind of versus pixie dust, and kind of go through it. I got a few objectives here. Explain kind of our general approach to all wounds. We have a really diverse kind of background, and so I'm not going to focus too much on specifics of an individual kind of dressing or what have you. That's a little bit too broad for this conversation. And then kind of more of a focus upon like what our clinic's approach is to this and how we can kind of help the patient out and help you out. And so again, it's kind of a general approach to all wounds that we take, and I apply some basic solutions like how would we handle diabetic foot ulcers, different kinds of leg edema, and how could you manage a wound vac if it's an issue and it shows up in your clinic or hospital or wherever and not sure what to do with it. And then the last is, I was going to talk about HBO, but I just came back from a conference and I am like challenged to keep my attention more than 15 to 20 minutes, let alone sitting that long. So I'm not going to talk about that today. If anyone does have any questions about that, they can just reach out to me directly, and I'm happy to talk about it further. It's just, I think, a little bit too much for today. So we'll kind of move on. I think if you can listen to this part, this is the message. Wounds are complex, physical, social, financial, and emotional challenges. If you improve the fundamentals, improve the overall wellness, the body will heal the wounds up with it. We at the
Looks like we lost audio.
Sorry, we lost audio. Trying to unmute Dr. Wyatt. Dr. Wyatt?
Let's try this. Is this any better?
There. Yes, thank you. I can hear you.
Okay. All right, we'll see how this goes. I switched from my phone to the little mic here, so we'll see how it goes. Okay. Now we get all that fun stuff. All right, so you guys can hear, we'll keep going. So anyways, you can contact us. Probably Epic Chat is the best way. You can attach the patient information, HIPAA compliance, and we can get back to you kind of quickly with it. So that's probably the key part with it. If you don't retain anything else, we're here to help. Wounds are complicated, and we can help you if you get urgent cases as well, to discuss the case and to get close follow-up. So what is a wound, right? So classic kind of presentation technique, you grab the dictionary definition of it, but I actually think it's pretty accurate. So it talks about an injury to living tissue and an injury to a person's feelings or reputation with it. So wounds impact, the physical and then the psychological impact as well. And impact is a wide range as well. It's not always related to the size of the wound. But I try to always imagine like myself in the patient's shoes. So just kind of pick a scenario where you're sitting there, doing fine, minding your own business. You develop some mild abdominal pain, then it slowly kind of progresses over a day or so. And you go into the emergency department, you get checked out, blood work, CT, and basically you wake up about 4 or 5 days later, probably at the time of discharge when you're kind of coming to. And this is what you've got. You've got a large abdominal wound with a wound vac in place. You've got an ostomy, which, to be honest, like would freak me out. I could handle a wound, but the ostomies really would intimidate me. And this is probably a great opportunity to just give a shout out actually to the ostomy nurses, because I think they do a fantastic job. These ostomies, as you can imagine, like are really emotional and really kind of technical as well. And they do a fantastic job educating and working with patients, primarily on the inpatient, both at all locations, Boise, Nampa, and Ontario. So they do a great job with it. But, going back to like, if this were you ready to head home, you would have a lot of mixed emotions with it. And that's what we see with most patients, right? So it could vary depending on who you are. Each person's a little bit different. What's the baseline health? What's your overall function level? What resources do you have? What can you do yourself or have social support? And what are your finances? And so you can kind of see all this stuff kind of as a blend of pain and fear and shame and the burden of it. And when you have this, as you all know, like these emotions amplify other emotions. So the more fear someone has, the greater their pain is with it. And so this is a major impact on people's healing, people's access to care, willingness to get care, and feeling cared for. And I think it's such a significant thing. You can even look at it from a historical perspective. How many times are wounds and wound healing mentioned in the Bible? I'm not a biblical scholar, so I just Googled it, but it's about 70 times. So it's pretty significant. Even, a couple thousand years ago, they were talking about how much of an impact this has on patients. So in addition to just the technical side of a wound, we deal with a lot of that emotional process, like the journey of wound healing. You're probably familiar with the Kubler-Ross grief cycle when someone has passed and patients or a family member's response, initial denial or anger, bargaining, depression, and acceptance. And we see that a lot with our patients coming in, and we kind of work with them and kind of walk them through all those different stages. And then ultimately, actually, I find it very satisfying that ultimately this goes from not just depression and acceptance, it actually converts into gratitude. This image here is actually patient made this wood cowbell for us with our logo on it. And the significance of that is when our patients actually heal and they graduate from the wound clinic, we have them ring a cowbell to celebrate it with it. And it's a really interesting kind of sight to see because it's so mixed, as there can be, cheers all the way to tears. There can be a tiny bell ring. Some people may be a little annoyed by it, all the way up to people shouting with joy with it. And sometimes a mix of all those with one patient. So, and although we kind of make a significant impact on patients, walking them through this journey, and I truly feel honored to do what we do. It's, I think, very unique and special. Sometimes it feels more like this, right? Kind of leading the horse to water. And ultimately, I think that is our responsibility and our duty with it. And so that's what we kind of focus on in trying to maintain our empathy towards patients. And when I first looked at this photo, I thought initially, like, I like the horse not drinking the water. Then I looked at the guy and I was just thinking how bad his GI disease is going to be after drinking this contaminated water. But then I actually thought it actually may be more appropriate to healthcare than I initially thought, because providers should, I feel like, do everything that they can for patients. It's our duty and professional responsibility. But we also need to protect ourselves, right? And in order to stay into the fight and hopefully to avoid a horrible diarrhea disease. So what wounds do we care for? Basically all of them, large, small, simple, complicated with it. And not all wounds are the same. It's not size dependent. And honestly, sometimes I think the smaller wounds we have the biggest impact on. Example is patients who've mild trauma, they got a hematoma in their leg or their arm. It's not going away, gets some necrotic tissue over the top, gets infected, rounds of antibiotics, admitted, and ultimately discharged to us. And then we actually debride that tissue. And that's when they actually can start healing. It gets rid of the infection. And so they're relatively small, but it has a big benefit on the patient. So who should get referred? Basically, if you have a concern, I think you should refer them. And maybe one criteria would be if you're anticipating kind of multiple office visits or urgent care or the emergency department visits, those would be good patients to refer to us to help out with. And sometimes it's not just like a directly related to a specific injury. One example is the emergency department took care of a Spanish-speaking female, young, she was pregnant. She had a large laceration. It was suture repaired, and the sutures need to come out in 10 days. But they did a follow-up with us in 2 days. And so we got them in. And this is an example where, from a wound standpoint, there really wasn't much to do. They should be coming out in 10 days. But who's probably at the highest risk for abuse, right? Probably this patient, Spanish-speaking female, pregnant, single, has traumatic injury with it. So it's not always directly for the wound itself. Sometimes it's social evaluation and additional observation. So what don't we take care of? So we don't take care of maintenance, kind of standard post-op care with it. That's kind of part of the surgical package with it. If there's complications with it, that's different. And then also ostomies, like from a wound standpoint, we don't do the ostomies. The ostomy nurses are in our clinic. So if it's just an ostomy question, that's who we send them to. Just do the ostomy nurses in our clinic with them. One of the things I really like about wound care, it's a team effort. So we have physicians, APPs, physical therapy, nursing, medical assistants, PSRs, hyperbaric oxygen technicians. We all kind of work together to create and implement a care plan for the patients. We have frequent visits with the patients. That actually is, I think, the foundation of creating trust and providing good outcomes for patients. We coordinate with home health as needed, and we provide short and long-term kind of care plans, hopefully not just sending them out into the wild, and really appreciate the support of the other specialties, vascular and ortho, for example, are fantastic. So let's actually talk about wounds themselves. What do we have? So this is not going to be a scientific lecture. I'm a pretty basic guy, but I think it's important to understand the 4 stages of healing. And these are them. So hemostasis, right? You got to stop the bleeding. If you don't do that, nothing else matters. Inflammation is basically the cleanup phase. Proliferation is where you actually grow new tissue. And then maturation is the remodeling phase where it's closed, but it's strengthening and gaining more elasticity and function. And that can last up to 6 to 12 months with it. I like to imagine this as almost like a house that's on fire. You got to put out the fire initially, right? You got to stop the bleeding. If you don't, nothing else matters. Next, with that house, you got to remove all the damaged, waterlogged carpet, burnt walls, and everything else. Once you clear out everything, then you can actually start to build. And then ultimately you can kind of do some fine tuning with it. So we try to support that process. And probably the most important area is actually in the inflammation or in the cleanup phase with it. How we do that predominantly with debridement, kind of removing unhealthy tissue, infection. Additionally, just providing a healthy, supportive wound environment, something clean, moist, and warm. And then also from a larger standpoint, metabolic optimization. So what's the blood flow? What's the diabetes, immune status as well? So I'm going to bring up a case here. Just kind of talks about, I think, or it illustrates the 4 stages of healing. So gentlemen, blood thinners, you can kind of tell poor skin quality in general, ground level fall, caught his arm with a large skin flap or skin tear. And I think they actually did a nice job with this. I think it was in the emergency department where they put just steri strips on it, compressed it down, reduced the skin tear to the full edges, put no stick dressing on there and a little bit of compression. But he was a challenge to get hemostasis. You can actually see still a little bit of bleeding in the steri strip. So I saw him a few days later. And what their primary concern was this large skin tear, this flap kind of up by his elbow on the right side of the screen. And you can see it's actually taking really well. But the area that was not a flap, and this was pretty deep. I mean, this was down, he had some exposed muscle. But you can see in the center of the screen, this hematoma with necrotic tissue over the top. And so this is that cleanup phase where the body's working really hard just to remove this clot, but he's got overlying dead tissue with it. So ended up debriding it with scalpel. And I think this one, if you're kind of assessing wounds, this has all 4 phases for it. So if you look down at the bottom edges, there's a little bit of bleeding. Again, he was on anticoagulation, so anything that you did, he kind of bled. If you look over on the left side of the screen, still some non-viable tissue that we were kind of working slowly to remove just because you had vessels and muscles just sitting right under there. To the adjacent to that, more in the middle, it's in this cleanup phase, early granulation, still some slough, and then more on the right side, healthy looking granulation with new epithelium on there as well. So already in the remodeling phase on some of these areas. So all I did was remove some unhealthy tissue. We used basic dressing, basically some nonstick dressing like a Zeroform and Aquacel, changed it about 3 times a week, and his body was doing all the healing. It was not anything, any magical dressing. We just kept the wound protected, clean, warm, and moist with it. Whoops. And I'm back there. So there's a statement in wound care that I like where it's what you take off matters more than what you put on to it. It would be wonderful if we had like a pixie dust, some amazing thing, you just put it on there and it would heal the wound no matter what. That is not the case with it. So basically what we see, if the fundamentals are taken care of, the wound will heals most of the time. Sometimes though, it does need some additional help. And so one of the areas that is, my opinion, kind of like a pixie dust, that can be very helpful is skin substitutes. So this is a photo of a skin substitute that's derived from placental tissue. And there's good evidence to support that if you've done all the appropriate cares, after 4 weeks, if you don't have significant healing, these skin substitutes can be beneficial. But they're about $2,000 per application. You do 1 per week, and you can easily do 6 to 8 of them with it. So pretty expensive, pretty quickly with it. But there is a time and a place for them. One of my partners here did a study that was not published, but I think was illustrates kind of the importance of fundamentals versus kind of expensive technology with it. So the study was for diabetic foot ulcers, and they were comparing 2 different kinds of skin substitutes. It was a small study, about 20 patients, and they used the gold standard of treatment, which is a total contact cast. And they did it for 6 weeks, and they paid the patients $100 a week to come in, to wear the cast, and to follow up weekly with it. And after those 6 weeks, all the patients who did not heal up would go into this study. So they had 20 patients go in, they used the basic technology of a cast, and at the end of it, how many do you think actually made it into the study? Right? None. They all healed up, and none required a skin substitute. So to me, I learned kind of 2 takeaways from that. One is the fundamentals work, and they're more important than kind of fancy technology. And the other is that if you pay a patient $100 a week, it actually improves compliance quite well. So, but let's talk about these fundamentals. What are we? I keep mentioning them. What are they? Well, first, we're going to talk about dressings. So this is my only slide on dressings that we're going to go through, just because every clinic's a little bit different. The resources are a little bit different, but the concepts should be the same across all. Right? So in general, you want a wound dressing that keeps the wound clean, keeps it warm, keeps it relatively moist, and possible, meaning can the patient do it themselves, or is there access to somewhere that can help them with the dressing? Can they afford the dressing with it? And then the other is the dermatologists, I think, are right in some regards where if it's wet, you want to make it dry. If it's dry, you want to make it wet. So an example is if you have a leg wound that is draining copious amounts of fluid, you want to dry it out. So you just put a pad on it, like an ABD, and that will help absorb all that fluid and get it off. You wouldn't want to use like an ointment because that would actually make something really wet even more wet with it. And then there are a few things that we do avoid. We don't use neosporin just because it triggers a lot of dermatitis in patients. Bacitracin's tolerated more. We use a lot of bacitracin for burns. We don't use hydrogen peroxide or alcohol, and minimal amount of betadine. Those on like wound beds are desiccants. They actually damage the new growing tissue, so we try to avoid them. Betadine we use basically on non-viable tissue. It does dry it out and knock down the bacteria as well. All right, so here we go. Here are the fundamentals that we're going to go through. This is a leaf from the mimosa plant, which was made famous by a French hotel that named their champagne and orange juice morning cocktail after the mimosa flower. And why I put it on there is this pattern. When you touch the leaves of a mimosa plant, they wilt away. And with barely touching it, it just falls apart. And you can see this starting to happen with it. And that's what happens with blood flow. If blood flow is compromised, it does something called pathergy, where even small amounts of trauma can actually make the surrounding tissue basically wilt away and worsen, right? So you may have a small wound, you debride it or do a little bit of trauma to it, all of a sudden it comes back twice as big. So triggers for this, peripheral arterial disease is a classic one, almost all forms of vasculitis and other conditions like pyoderma gangrenosum. And a lot of times, that's how some of these, like the PG or vasculitis, are diagnosed. You'll like debride it, and all of a sudden it is a lot worse. It's very humbling. The less that you do, the better the patient does with it. But looking at kind of classic PAD type patients coming in, how we assess them, one is like looking at this, does it's kind of cool, no hair on this patient's foot or leg. No pulses, kind of discolored distally, kind of this dark Eshar wound. Talks about having some pain at night when he's resting. In this specific patient didn't have claudication complaints. But we checked ABI as well as TBI, which is the toe brachial index, which is actually more sensitive for toe blood flow. It was abnormal, so we would refer him to vascular. It was not emergent, but had long conversations with him that these can convert pretty quickly with it. And our overall goal is to actually protect these things. Because of that pathergy, we're not going to do much with them until the blood flow improves. So we paint it with some betadine, bulk it up, and have close follow-up with them. Second major area from a fundamental standpoint is pressure. This impacts true pressure injuries. This is also what impacts diabetic foot ulcers, which is actually just a pressure injury by a different name with it. And there's kind of three different forces that you'll see with pressure injuries. One is direct pressure, right? If someone's down on a hard floor, that direct pressure to their skin will cut off that blood flow, leading to necrosis. Friction can do similar things, obstructing or modifying the blood vessels underneath. And then shear force is similar to friction. It's just not moving as much. You're just pulling it, but it deranges the blood flow to that tissue, causing decreased blood flow and necrosis and skin breakdown with it. As I mentioned, these impact both true pressure injuries as well as a mechanism for diabetic foot ulcers. And if pressure is the problem, then taking the pressure off is the solution for these. So how do we do that? And I'm going to focus on diabetic foot ulcers, but the concept is the same. If pressure is a problem, you got to take it off in some fashion. And so for diabetic foot ulcers, we use three different kind of primary modes. One is on the left here, a Darko shoe, kind of a post-operative shoe, commonly used for broken toes. It doesn't actually offload pressure from the foot. It can redistribute it. Unfortunately, patients' compliance, they a lot of times will accept this versus true offloading. So we kind of start with this sometimes. The next one in the middle, it's called a Bledsoe boot or an offloading boot. And these are different than immobilizing boots. So this and the cast, the total contact cast next to it. The concept is when you are fitted with these and you step down, all of your weight is captured in essence in the calf area. And the foot should be floating in space. The bottom of the foot should not have pressure on it. So that is true offloading or getting that pressure off with it. So these are the techniques that we use in the short term when patients come in with a diabetic foot ulcer to get them to heal up. Clearly, like the amount of offloading you need to heal is greater than what you need to prevent a wound. But how do we help prevent these long term, especially with diabetic foot ulcers? Well, diabetic shoes, right? So here's an image of some. Here's some numbers up top. They're about 10 years old, but they're probably accurate or, from a cost standpoint. 5-year savings from a cost saving standpoint for diabetic shoes, say $10,000. Treating one diabetic foot ulcer, estimated $7,000 to $20,000. Major amputations, $70,000. Lifetime cost of that is $500,000. And these are always probably significantly more. Like I said, those numbers are 10 years old with it. So clearly diabetic shoes are worth their weight in gold with it. And to me, if you want any evidence that these are effective and worth the effort, is that insurance companies will actually pay for these. They don't want to spend money on anything, but they pay for their shoes. So that is evidence that these really do prevent wounds and ultimately healthcare cost with it. So what we end up doing, we write a lot of prescriptions for these so that they can get custom molded inserts and shoes for it. And then after they get those shoes, we have them come back and we pressure map them. And so that's where we put a little digital insert into their shoe. We have them walk and we can assess the pressure that's impacting the bottom of the foot. And so this isn't a truly accurate image here, but you can see kind of the red areas are where there's excess pressure, put the orthotics on, greatly minimize that. But the power of this is it allows us to anticipate knowing the amount of pressure that they will develop a pressure injury in the near future if they keep wearing these shoes. So we do the test, we make recommendations, and they go back and get their shoes modified. And I think that's the key thing is that although they're expensive, the shoe suppliers should be able to modify the shoes. And if not, then they're not really diabetic shoes. They're just supportive shoes with it. All right, so let's talk about infection kind of briefly. Pretty straightforward. I think so. You need source control. You need quality wound cultures. That's typically after debridement. And if it looks infected, you give antibiotics. A lot of wounds are not infected. But if you are seeing a patient with a diabetic foot ulcer and you've got a concern, pull the trigger. Put them on some antibiotics with it. It's better be safe than sorry. But for the most part, people have, these chronic wounds. They may have bone infection and they look pretty stable and they wouldn't need immediate antibiotics. But at least from my standpoint, I would not shame you if you put them on there prematurely. So what antibiotics will we use? Pretty general. This is actually recommendations from American Family Physician from 2021, and I kind of agree with it. Just assessing what their risk profile is. Do you want to do double coverage for MRSA coverage with it? But probably the most important thing when we're doing this is source control. A lot of them, if it's infected tissue, it needs debrided and in addition to the antibiotics. One thing that is changing, which I think is actually good for patients, is historically patients who've had osteomyelitis have required at least prolonged antibiotics, typically 6 weeks, requiring a PICC line and IV antibiotics. But more and more research is coming out indicating that for the right candidates, can they absorb antibiotics and tolerate it, that PO antibiotics are just as effective as IV antibiotics in general with it. And clearly there'd be a lot fewer complications related to a PICC line and other things that you would not see on the PO side of it. Okay, so we're going to move on to immune suppression. So this one is a mixed bag of both not having an immune system, therapeutically suppressing immune system, and then as a side effect. So probably the biggest one that we see is related to diabetes, and it does have an impact. One research indicated that if your A1C is greater than 8%, your risk of a lower amputation with a wound goes up by 5-fold, right? So 8%, at least in our book, is actually not that high, but multiplying your lower extremity major amputation risk by 5 is pretty significant. So clearly that's a modifiable factor, not only just from the ability to fight infection, but you need your immune system to grow new tissue as well. So cancer therapy, there's kind of two major categories, at least how I view in it. One is there's chemotherapy that can have a direct impact on the immune system or on the immune cell lines with it. And there's others that aren't so much immune suppression directly, but they're inhibiting. So angiogenesis, Avastin is one that you see with this, that it's a phenomenal therapy where it's inhibiting the angiogenesis or blood vessel development in new tumors, inhibiting them. However, what are we trying to do? Healing a new wound, we're trying to grow new blood vessels. So that really impacts the wound healing with it. And on from a Avastin standpoint, they typically indicate after surgery, it should get restarted about 6 to 8 weeks after a significant surgery from a healing standpoint. From my standpoint, I actually think chemotherapy or any of the oncology therapies trump wound care for the most part, right? If it's a priority and they need it, we can manage a wound long term. If we can hold off on some of these therapies for 2 months, that would be fantastic. But we can take care of wounds in a palliative fashion as well. And then the last area is autoimmune conditions and the inflammatory conditions such as vasculitis or pyoderma gangrenosum respond well to prednisone and other immune modulators with it. It's actually kind of a paradoxical response because patients who have inflammatory issues, when they're put on immune suppression, they seem to heal up very quickly. But patients who are put on, say, prednisone for COPD, we see it inhibit their healing. So it's an observation. All right, last thing is overall edema. There's different causes of edema, but this is a kind of a basic animation that I made. Don't make fun of my skills, but basically, if you want to look at these are blood vessels and the distance between them in terms of perfusion and nutritional exchange, there's a certain distance between the different capillaries with it. And when you bring in more edema, those spread apart with it. And then as a result, you have a gap where decreased oxygen, decreased nutrient exchange with it. So getting that overall fluid status down and fluid out of that interstitial space is beneficial for wound healing overall. So this is an example from one type of edema, kind of venous stasis, kind of classic symptoms of hemosiderin staining. You see a bunch of varicosities down below, has a couple of venous stasis ulcers here. So how we typically handle these is compression, elevation. Overall fluid status is important, but there is a point where you can't diurese them. Like if they're fluid overloaded, yep, diuresing really helps. But once you get to that point, that's where compression is required, and in addition to elevation with it. And when we do see patients like this, we'll often refer them to vascular to assess from venous insufficiency and reflux, and if they can intervene with it. Another major cause of edema is lymphedema. You can see this is a very different kind of appearance. It's much more bark-like, kind of woody and cobblestoning, very fibrotic, almost like bark-like with it. The pathognomonic sign is the stemmer sign, where you try to pinch the second toe and it should stent, kind of pinch it together. You can see here, they're trying to pinch it and it just doesn't go together because it just has so much fibrotic change with it. Typically, a lot of these in the US, it's related to, sometimes it's primary, just idiopathic or genetic. A lot of this is related to post-surgical issues, post-radiation for cancer, removal of lymph nodes or irradiation. Worldwide, it's actually filaria, parasitic infection inhibiting with it. But you can see the impact on overall people's lives. But both types of edema are managed with compression, weight loss, activity. And for the lymphedema, once the wounds are healed up, we try to get them in with the lymphatic clinic for lymphatic massage, which is very beneficial as well. So how we do it, compression, different forms of it. We have the formal wrap, Coban 2, Uniboot, multi-layer wraps, tube grip, Tettos, and even an H wrap. And I think it can be helpful if someone's like in the urgent care or emergency department, they get lower extremity edema with laceration. If they got pulses, I think putting a little bit of an H wrap compression on there can really help them out for a day or two. This is a simple tube grip that can be a short-term fix, but also long-term, we do get them set up, sometimes pneumatic pumps, Velcro wraps, dual layer socks, tube grips, and even something called edema wear with it, depending on the patient's ability and needs. We'll move on to nutrition. As you all know, good nutrition is important for everything, not just wounds. This might be one of the most challenging, actually, barriers with it, habit, cost, behavior, access to wound care. We encourage real food, real protein with it. Actually, I looked at this image. I think if our patients, all of our patients ate this type of food, we probably wouldn't have as many patients. How about supplementing? Evidence is kind of mixed. So if they're deficient, it's clearly beneficial, right? So vitamin C, there is scurvy in the US. A lot of times it's like a single male who they've lost their wife who's a primary food maker, and now they're just eating hormel chili. But if they're not deficient, supplementing has a mixed result. So I don't know if it's kind of worth the cost and effort with it. Then back to our prior case, removing barriers in terms of like non-viable tissue, it reduces the risk of infection and is literally a block to healing forward. So there's different options from a debridement standpoint. We use scalpels and curettes for sharp debridement. We use moistened gauze for mechanical debridement. We use silver nitrate to cauterize for chemical debridement. Santal is often used, which is an enzymatic debridement as well. And we even use medical baggots that can be effective, but we actually find probably the free range maggots more often than the medical maggots. So that's kind of the basic review of the fundamentals that we kind of go through. As I mentioned before, wounds are really complex and patients need significant amount of emotional support. And I had a friend recently have his finger surgically amputated, and thank goodness for his friends providing good emotional support. And they gave him this. These are just cookies in the shape of his amputated finger with it. So I kind of look at this like, what are friends for? Good moral support here. But let's move on to a few cases and how we'd handle them in the clinic. Probably got about 5 more minutes with it, so it'll be perfect. So 55-year-old diabetic, peripheral neuropathy, lower extremity edema for about 2 weeks, new redness with it. This is kind of the appearance of it. Going through the fundamentals, blood flow. We checked good normal studies, so no concerns about peripheral arterial disease. Although diabetics can still have some microvascular disease that can inhibit healing, but no major intervention. Want to offload this area. This is a pressure injury again. It's a diabetic foot ulcer, so we would put him into a Bledsoe boot that takes the pressure off of that foot. We would probably treat him empirically with some augmentin. We would debride the wound and grab a culture. At this stage, we typically don't grab any imaging unless there's something concerning on exam. His A1C is 12%, so coordinate with the diabetic educators or family medicine or their primary care with it. He did have some chronic edema, so we added just a tube grip, low suspicion for DVT. Talked about glycemic control, education on nutrition, debrided the tissue, got a good wound culture that was kind of viable that may guide us in the future. And a pretty basic dressing, basically some iodosorb, which is an iodine-based treatment, and an absorbent pad, changing a couple times a week, because the primary treatment for this is getting control of the infection and getting the pressure off of it. Long term, if we get him healed up, we'd get diabetic shoes for him, as well as get him pressure mapped afterwards. All right, so leg edema. So 72-year-old, chronic history of lower extremity edema, got signs of staining. He's got a new wound on the medial aspect with some serous drainage, no spreading redness to this, no signs of PAD or DVT. ABI is performed, nothing. Do notice, chronic issues, chronic varicosities down below, so we might refer him to vascular assess for venous reflux. No signs of infection. We don't start him on antibiotics. It's not diabetic. No issues with immune suppression as well. Compression, start with the Coban 2, changing it a couple times a week, and long-term transition him to kind of specific compression socks that he'd be able to don and doff with. If he does not respond to kind of this typical treatment, sometimes we will biopsy, because these are also areas that people can get a skin cancer as well, and don't want to be fooled into this being just a venous stasis ulcer. All right, so that was kind of it for the cases. We're going to do a very kind of brief review on wound vacs with it. So wound vacs are great, but again, they're not perfect. It really depends on the patient and where the wound's location is at and how they respond. There's 3 main kinds of wound vac. So on the left, we call it Activac, or KCI is the brand name, but you can see this is more of a wound vac that has the, I'll go back here. I'm sure most of you are familiar with this. On the wound standpoint, you put black foam on, basically plastic cover, and attach a suction hose to this device. These are larger, they're rechargeable, they have a canister that can be replaced. So large wounds that have a lot of drainage, this is what should be used. The Brevinas, there's a mix of them, but they're typically temporary, put on after surgery and left on, and once the battery kind of runs out, they are removed, typically on actually enclosed wounds with the primary closure with it. And then there's also something called a snap vac, which is more of a mechanical thing for smaller wounds that we will use at times with it. So again, they're helpful. They're not perfect for everyone. Sometimes we actually switch from a wound vac to even moisten gauze, and sometimes that's more effective. We do change these twice a week in our clinic. Wound vacs are great until they don't work, and probably the primary issue is that they will lose a seal with it. Their patients are provided with a lot of education. There's good hotline or help hotline that they can call to try to get these fixed. But if it's not functioning and you lose the seal or lose the suction, it should be removed within 6 hours. If not, all of a sudden, I just imagine it's kind of holding on to like a jar of mayonnaise, all the bad stuff in there. So it can be removed. If you do have concerns for an infection, even if the wound vac is working, go ahead and remove it immediately. For both of them, you can just use moistened saline or saline moistened gauze to replace it. Change it a couple times a day until the wound vac is decided to place back on or not. It is a great tool, but it's not magic, and they're easy to put on and take off with it. So if there's ever a concern, feel free to take it off and just use moistened gauze in the interim. So in conclusion, wounds are complex, physical, social, financial, and emotional challenges. If you improve the fundamentals, the body takes care of the rest. There's no pixie dust. We try to help out all patients in all kinds in the wound clinics. If you have concerns, you can contact us. But I think the key message is like when you actually improve, no matter what specialty you're in, working on improving diabetes, blood flow, and even their psychiatric state, you are improving their fundamentals, like their overall well-being. And so as you do a great job in those areas, you're actually helping to heal all of these wounds with it. So that's all I have. I'll be open to some questions and go forward.